So we already discussed about the benign lesions of the oral cavity, then we talked about some premalignant lesions, and now let's move on to the actual carcinomas or cancers of the oral cavity, and the first we will talk about the carcinoma of the lip. In this section, we will talk about what are the sites of the development of cancer in the lips and oral cavity, local and lymphatic spread, and also what are the investigations done and the treatment for the carcinoma of the lip. The malignant lesions, carcinoma of the oral cavity, the causes or etiology is the smoking. 6 times more chance of cancer in smoker and the cancer of the hard palate. Then the tobacco chewing is the other common cause of the development of the cancer of the oral cavity. Powdered tobacco mixed with lime at site of quid in vestibule. So these are some sites of the development of the cancer in patients who do the tobacco chewing, especially mixed with the lime. Alcohol is cause cancer of upper aerodigestive tract, 6 times more chance in heavy drinkers. Dietary deficiencies, different dietary deficiencies like Plummer-Vinson syndrome, riboflavin deficiency, cancer of oral cavity, and hypopharynx. So these are some dietary deficiencies that can cause cancer of the oral cavity. We have Plummer-Vinson syndrome, riboflavin deficiency, cancer of the oral cavity, and hypopharynx occur with these dietary deficiencies. Other causes can be the dental sepsis, jagged, sharp teeth, ill-fitting dentures. All these can cause the irritation, and chronic irritation, we already mentioned, can lead to the development of the cancer of the oral cavity. So some causes, etiologies of the cancers of the oral cavity, we have the smoking, tobacco use, alcohol, dietary deficiency, and some other factors like the irritation caused by ill-fitting dentures and the sharp teeth. Sites of cancer in the lip and the oral cavity, we have the sites mucosal lip, then we have buccal mucosa or the cheek, anterior 2/3 of the tongue, hard palate, lower alveolar ridge, upper alveolar ridge, floor of the mouth, and retromolar trigon. All these are these common sites of the development of the cancer or malignancy in the oral cavity. We have the anterior 2/3 of the tongue, hard palate, alveolar ridges, then the both upper and lower, upper with the upper teeth, lower with the lower teeth, lower jaw, upper jaw, and then floor of the mouth, below the tongue, and then retromolar trigon. All these are the common site for the development of the cancer. Carcinoma of the lip, squamous cell carcinoma. So the carcinoma of the lip is the squamous cell type. You can see the picture, get really bad ulcerated lesion. Again, this is a little more nodular type of the lesion is present on the lip. So squamous cell carcinoma on histological appearance is the squamous cell. The lower lip is mainly involved, lower lip carcinoma, then predilection between midline and the commissure. So it's between the midline and the commissure, the more commonly it is present. So more in the middle or on the side, towards the side or the ends of the lips. Submental and submandibular. Submental is below the chin and mandibular is these lymph nodes which are commonly involved and mostly affected. Deep cervical nodes are involved later in the process of the spread of the carcinoma of the lip. So it's squamous type carcinoma. Lower lip is mainly involved in the median or the commissure side, and then we have submental, submandibular lymph node. But later, as the disease progresses or as it spread, deep cervical lymph nodes are also involved. Site of origin of the lip cancer, angle of the mouth. This is the angle of the mouth which is commonly affected. The line of occlusion of upper and lower teeth, where they come together, the upper and lower teeth, that's the line of occlusion of the upper and lower teeth. From buccal sulcus multicentric, there is also the site of the origin of the lip cancer. The gross appearance, how it appears grossly without the microscope, there's exophytic lesion. It's exophytic type of lesion. Ulcero-infiltrative type, ulceration type, it's like ulcer and it penetrate deep, infiltrate deep. So that's the gross appearance of the tumor or cancer. Deep infiltration occurs. Erythroleukoplakia, both reddish and whitish patches are present. Erythroleukoplakia. Buccal mucosa is the common site for the development of the lip cancer, and it's verrucous carcinoma, keratinized papillary growth. So all these are the different sites of the origin and the gross appearance, how the tumor of the lip looks like, and carcinoma of the lip appear grossly on the gross examination. Local and lymphatic spread. It can spread locally to the submucosa muscle and subcutaneous fat skin. All these are the sites where it is infiltrated locally and involve all these different structures. Buccinator muscles or buccinator muscle or anterior masseter involvement is there. And then we have radial spread, upper gingivo-buccal sulcus, maxilla is involved also, and mouth and lip anteriorly is involved, retromolar trigone and medial pterygoid posteriorly is involved. So all these are the sites which are locally invaded by the infiltration of the tumor, spread of the tumor, and these are the local area, not the distant metastasis where this tumor is spreading locally. Lower gingivo-buccal sulcus and alveolar ridge and gums inferiorly. Then we have lymphatic spread to the nodes, lymph nodes 50%. Submandibular and jugular nodes are most commonly affected. And then also we have skipping of submandibular group. So the most common lymph nodes affected are the submandibular and the upper jugular nodes, and then we have 50% of the nodal involvement. So this was all about the local and lymphatic spread of the carcinoma of the lip. Clinical features are the asymptomatic lesions. Sometimes no features are present, so it's asymptomatic. Pain and bleeding is present. Then we have ulcerative lesions, trismus, lockjaw, fungating mass over the cheek, and foul smelling bleeding mass. All these are the clinical features of the carcinoma of the lip. We have asymptomatic lesions, pain and bleeding, ulcerative lesion, trismus, fungating mass over the cheek, foul smelling bleeding mass. Investigations and treatment of the carcinoma of the lip. We have biopsy. As with any malignancy, biopsy is the very important for the diagnosis. CT scan. Treatment is the stage 1 is T1, no nodal involvement, surgical excision. Stage 2 is T2, no nodal involvement, again radiotherapy to primary lesion and nodes, and then we should do surgery, segmental mandibulectomy, and then skin or mucosal flaps. So in stage 2, both the surgery and radiotherapy is performed. Stage 3 and 4, surgical resection, reconstruction of the area, post-operative radiotherapy, and the neck dissection. So all these are the different steps for the treatment depending on what stage is the lesion. So we have just the surgical excision, then we have radiotherapy followed by surgical excision, and then we have surgical resection, reconstruction, radiotherapy, along with the neck dissection, especially when the cervical lymph nodes are involved and affected. Squamous cell carcinoma is the most common type of the lip carcinoma. Non-squamous malignant lesions are the minor salivary gland tumors, 80 to 90%. Common site is the hard palate, involves tongue, cheek, lip. Adenoid cystic is 40% of the time. Then treatment is surgical excision and block dissection. Another non-squamous type of malignant lesion is melanoma. Palate and gingiva are the common site. High pigmentation and ulceration, since it's melanoma from the pigment forming cells. Amelanotic variety. Wide surgical excision is the treatment. Local recurrence is common. It can occur locally after the treatment or the surgery. Then we have the lymphoma. Lymphoma is in the palatine tonsils. Males are more affected. Submucosal ulcerated bulky mass is present, non-Hodgkin variety. Lymphomas can be Hodgkin and non-Hodgkin lymphoma. In this, the non-Hodgkin type is common. Radiation or chemotherapy is the treatment. Kaposi sarcoma is vascular tumor, multifocal. It is high in the patients who have AIDS. Reddish purplish in time, nodule or plaque on palate. So different types of the non-squamous malignant lesions are present, in which we have the minor salivary gland tumors, melanomas, lymphomas, and Kaposi sarcoma. Squamous carcinoma is the most common, but then we have some non-squamous type also, and in this non-squamous type, minor salivary gland tumors are common. 80 to 9% are malignant, and 40% are the adenoid cystic. And then we have another, it's Kaposi sarcomas. They are hemorrhagic, cleft-like spaces are present in the Kaposi sarcoma. Chemotherapy in non-AIDS patient, the treatment is chemotherapy if it is not associated with AIDS. If it is associated with AIDS, the treatment of the AIDS as the underlying cause can cure the Kaposi sarcoma also. Chemo prevention. Pharmacological agents can be used, different drugs can be used as chemo prevention. We have vitamin A, beta carotene, alpha tocopherol, vitamin E, selenium, and retinoid, which is 13-cis retinoic acid. All these are used for the prevention of the carcinoma. Trials for COX2 inhibitors, celecoxib, can also be tried. So there you can see this is the normal cells, and then slowly there are the premalignant clonal expansion, then they become malignant cells. So normal cell, there is after the action of different things, different carcinogens, changes occur, and it becomes pre-malignant clonal expansion occur in the cells, and then they lead to the malignant cells here. Beta carotene and vitamin A induced remission of oral leukoplakia in 25 to 50% of the cases can occur after the treatment or the use of vitamin A and the beta carotene. So this was all about section 3. Thank you for watching sqadia.com.